All right, welcome to Healthcare Finance. We're going to jump in this week with a pretty easy chapter, but don't get fooled. This class is going to move very quickly, and it's really going to build on itself. This is the first time I've used this book. I used a previous book in the last time I taught this class that I thought went way too in-depth and way too far for undergraduate. Doesn't mean we're not going to cover a lot of material. I want to give you a basic understanding of healthcare finance and have you be able to pick up any hospital or medical provider's financial statements, their balance sheets, and be able to read them, dissect them, find out what's positive, find out what isn't, and move on from there and come up with strategies to solve it. So we're going to kind of work from that setting this semester to teach you kind of what I've learned over the last 25 years of healthcare. I also teach a marketing class. I've got a marketing undergraduate degree, and someone told me very early in my healthcare career, when times in healthcare are good, the marketing guys are king. When times are tight, the guys who understand finance are king. Times are going to be tight in healthcare forever. We are done with the heyday, and times are changing, and they're changing at a much more rapid pace in this industry than they ever have. So I want to give you tools on how you'll manage and give you a good, solid understanding of healthcare finance this semester. Again, I also made a note in my notes that are in the syllabus that I am not a professor. Just call me Blaine. Feel free to reach out to me that way. If you're more comfortable calling me Mr. Claypool, go ahead. I'm most comfortable with Blaine. So just work with me from there. All right, let's get started. And the objectives. In this chapter, we want to be able to kind of compare healthcare with other businesses. I'm going to cover the PowerPoint lecture, but I encourage you to read the book. I encourage you to have the book, whether it's an online version or a hard copy, you're going to need it. So you want to look at what healthcare and how we compare to other businesses. What's the background of financing healthcare in the United States? It's been fascinating. It's changed over decades, and now it's changing yearly, every 3 months, seems like. There's a new model coming out, and we're being pulled in a different direction. So we'll talk a little about the growth of inpatient facilities until the 80s when they've declined, and they're still declining. You look today and go out on Beckers.com. You look at Becker's Healthcare, and you read that there's hospitals closing all over the country. There's good reason, and we'll get into that this semester also. And you'll be able to kind of talk about what services are now provided in outpatient settings. We want to be able to look at analyzing the growth of outpatient and home-based services. You can understand what's driving those and why. What are nursing homes, life care facilities, hospice care? What are they? What are proprietorships, partnerships? What are PCs and LLCs? How do they affect liability? And then how do you differentiate among for-profit, not-for-profit, and governmental healthcare organizations? We're a very unique industry, heavily regulated, but we've got for-profit representation, not-for-profit, and we've got government-based organizations, all of which account for finances the same way, but all of which put different degrees on how they operate based on those financial statements. So, financial management of healthcare facilities. If any of you have had healthcare accounting yet, you know that we use accrual-based accounting. There are many reasons why we do that, the largest of which is calculation of net revenue. Net revenue is paid by a third party. Oftentimes, very rarely does the patient bear the entire brunt of the bill. When we are paid by third parties, we have to get bills out the door. Hopefully you get them out in 4 to 8 days after discharge. 5 days is a very good industry benchmark. But those insurance companies can have 30, 60, 90, and if they pinned or ask questions on a claim, it could go 120, 150 days till you get paid. That's why we can't book our revenue based on cash. We accrue it in the month that the revenue occurs. And so we use accrual-based accounting to match revenue to the month that it was generated and expenses to the month they were incurred. So we have a snapshot of what occurred during that 30, 31, or 28-day period. Again, most of the cost of our services are paid by third parties. They're paid by insurance companies, governmental agencies, and we've got to manage those third-party contracts and bills. We've got to know how our billing works. We've got to know how to collect. That is the lifeblood, and cash flow is king. We have a unique mix of healthcare providers and payers. We do not have a single payer system. Across the world, there are a number of single payer systems. We're not like that. We have governmental agencies, Medicare, Medicaid, which is a hybrid between the state and federal government that pay for health care. We have for-profit businesses, for-profit and not-for-profit payers and insurance companies, Blue Cross, Aetna. Then we've also got for-profit, not-for-profit, and governmental agencies that operate hospitals. So it's a varied mix, and all of them have different nuances in how they look at the financial statements. We all use the same accounting principles to record, but when it comes down to what we do with that information, it is a little different. Healthcare is a very heavy regulated business. I've heard it said earlier, the only thing that is more regulated is the airline industry. Well, that would make sense because the airline have many individuals' lives in their hands, and so do we. So regulation is actually a good thing in healthcare, and learning to navigate within that regulation is part of the complications that are very difficult to teach in a theoretical classroom setting. But as you get out there in the field and you start working in your chosen career in healthcare, you start learning the regulations and learning how to navigate them, learning how to meet them, learning how to identify what the real intent of the regulations are. So in addition to just being regulated, in a number of states, you can't just bill the hospital. They have certificate of need programs from federal or state governments, so you can't just expand at will. We're not really a free market economy in healthcare. There are states where it rolls along those lines and it's very close to a free market, but there are barriers to entry for payers, barriers to entry for providers. Clinicians are limited by state regulations. A physician in Nevada has to apply for a brand new license in Florida or in Oklahoma or in Texas. Very little reciprocity. They recognize it, but it still requires 90 to 180 days for them to go and validate the license and check credentialing. Hospitals are required to do primary source verifications on physicians when they come to the hospital to begin practice there. That means we have to go all the way back to their residency program and validate where they went to medical school and validate they completed a residency. So we are very, very regulated in our field. Financing healthcare in America has gone through changes over decades. And again, recently, with the Affordable Care Act, our reimbursement and our financing is changing dramatically. Prior to 1900, the medical profession was a free enterprise. The doctor made a home visit. If you paid him with a chicken, you paid him with a chicken. You know, if you paid him with doing services to repair the fence on his farm, you paid him that way. You paid an agreed upon fee. It truly was a free market economy, and it was a free trade where I had a service, you wanted the service, we negotiated what you were going to pay, and it was taken care of. There was no insurance. There was really no healthcare insurance. If you had a voluntary healthcare policy, it really covered your lost wages. It didn't cover what you paid the hospital or the doctor or anything like that. It covered what you lost out on. After 1900, you saw hospitalization insurance start to rise. Part of this was due to the Great Depression. We can no longer rely on charitable donations for their funding. A lot of that money had dried up. Blue Cross formed as a not-for-profit corporation in 1933 to find ways to insure individuals and cover their hospitalization stay. And then private for-profit companies followed. Physician services weren't covered still. They covered the major catastrophic cost of hospitals, but physician services were still on upon agreed upon fee schedule and negotiated individually. Not too long, though, later, physician services insurance companies were formed. Blue Shield actually formed in order to cover the physician component. So you had Blue Cross, and then you had Blue Shield. Blue Cross covered hospitals. Blue Shield covered the physicians. It's become synonymous, Blue Cross Blue Shield, or now you're called Florida Blue or Anthem. Pick a name. But now that you've seen the inpatient and outpatient and the physician hospitals merging together, private for-profit insurance companies, there was margin to be made. People came in and they had combined coverage for hospitalization and physician services cost, where they actually went in and rated populations, rated with a T, populations, and found ways that they could minimize their risk, spread their risk, and make a margin off of premiums. Combined health insurance programs really expanded rapidly during World War II. During World War II, wages were frozen, so benefits were used to attract workers. Those benefits were insurance. So the model that we live in today, where employers provide insurance, really came out of that era when wages were frozen and benefits became the way to compete. And they started going out and providing healthcare in different models, whether it was insurance. And if you really go back and research the world of Kaiser, the Kaiser Jeep Company, when they first started manufacturing and they ended up providing healthcare for their employees, they chose to do it by building their own hospitals and clinics. That's kind of what they do today. They're a closed market today. But there were lots of benefits established to attract workers, and that further separated the individual from the true cost of their health care. We took the individual financial interest in their health care out of their hands in the 30s, 40s, and 50s. It became you paid an insurance premium, whatever the hospital or doctor billed, your insurance company paid it, and you became less in touch with the cost of health care. And if you've studied any economics, there was no price sensitivity at that point in time. People were no longer sensitive to price. They stopped shopping. You stopped having to find out which doctor would give you the best rates, which hospital would give you the best rates. It didn't matter. You went and your insurance paid it. So we took a piece of that free market, and that's where you see us start to pull the free market apart and start to pull those economic incentives and disincentives away from the consumer overall, which led to a free-for-all in spending in healthcare. In the mid-60s, Medicare and Medicaid came into being. The federal government chose to fund healthcare for the elderly and poor. As people became price desensitized and as hospitals and physicians were able to charge, the expenses started to grow. Coupling with changes in technology, technology was starting to be enhanced and starting to grow, and it was becoming more expensive. The elderly had no way of taking care of themselves and were facing large hospital bills as they were getting sicker, as they were getting older. And the federal government stepped in to make sure that we had a safety net for the seniors in our country. Hospitals at that time were paid 80% of a usual charge. Usual charge was defined based on your cost. If you sat down and calculated in your cost, including overhead and profit and salaries, and there were also cost differentials thrown in there for salary and wage index. So the more you paid your nurses, the more you paid your staff, it impacted your wage index and it impacted your usual and customary charge, and you got paid more. And you were able to make a margin on that. So as you raise salaries, you made more money off of the federal government. It's interesting today to look at all of the hoopla and complaints about the Affordable Care Act and it being the end of healthcare and the end of society. If you research what happened with Medicare at the time, it was going to be the end of healthcare. It was going to be the end of the Great Society. We were going to be socialist. The Medicare law was changed many times in its first few years. We're reliving that today with the Affordable Care Act. Where Medicare came in and met a need that was there, that's what the Affordable Care Act is doing today. The Affordable Care Act is actually taking our healthcare system, flipping it over, and going from episodic payment and siloed healthcare and forcing us to start to think in a continuum of care. And actually, for the first time in this country since the 1900s, focus on preventative care and that family home doctor that took care of you and knew your family and helped manage your chronic conditions and kept you out of the hospital. There'll be times this semester I talk a lot about the Affordable Care Act and where we're going, and willing to set up a discussion board if anybody wants to discuss it and hear thoughts on it. We can go that way. Medicare was on a cost basis. There was no incentive to control cost. Cost of healthcare in the United States skyrocketed. There's a great article I'll find and post as soon as I do that talks about what really caused the increase in healthcare cost in this country, and it was this. It was Medicare and Medicaid, and it was the federal government coming in and setting rates and saying this is what the rate control will be, and we'll pay you X% of the usual customary charge, and we were off to the races. In an effort to try and change that curve and lower the cost, in 1982, the payment basis changed, and we began to be paid on a prospective payment system on DRGs, diagnosed related grouping. If an individual comes to our hospital for a knee implant, we may get $3,500. That is if they stay 2 days or if they stay 200. Whatever diagnosis, and every diagnosis has a designated fee that we are paid for that. So that changed the entire payment system. Again, in 1982, it was the end of healthcare. We were regulated again. It didn't. We adapt. We know what the payment mechanisms are, and we go from there. A number of private insurers adopted very similar systems on whether they're paying you on a DRG basis or whether they pay you a per diem, that regardless of what you do for the patient, you get $1,300 a day. It became and has become extremely complicated to manage a contract with an insurance company. You'll get paid a certain rate based on this diagnosis, but based on implants you get this. Based on these carve-outs you may get paid cost plus 10%. Based on these pharmaceuticals you may, or this may be disallowed. Extremely complicated financing system we live in today. Fee-for-service was deemed too costly. Just paying someone a percent of billed charges was too costly. All hospitals had to do was raise their cost. I spent a tremendous amount of my career in the state of Nevada, and Nevada implemented price controls. They basically came to all the hospitals and said, you can't raise rates by more than 8% a year. Okay, so guess what the hospitals did? They raised rates by 8% every year. In 5 years, the cost of healthcare had grown greater than 40% because it compounds. So rate controls don't work. And that's where you saw health maintenance organizations start to emerge, where they became the gatekeeper and they tried to set up that primary care physician that controlled access to care and limited access to specialists. So it wasn't just you went right to the specialist and got whatever esoteric treatment you wanted. Preferred provider insurance contracts, where providers came in or payers came in and negotiated with hospitals and said, you'll be the only hospital in our market if you give us the steepest discount. So we started negotiating with everybody. That then made the contracts more complicated to manage. Capitation plans became in vogue. And if you look at where we're going today with ACOs, we're kind of moving back to capitation with population health, where we're trying to set up fully integrated delivery models, horizontally and vertically integrated, and we want to accept a per member per month rate and be responsible for their health care. Well, that's capitation. That's kind of putting hospitals and healthcare ministries and healthcare systems back into the driver's seat and moving further and further away from a private insurance taking all the risk. The private insurance companies are now shifting their risk onto the healthcare providers. So a variety of type of medical businesses that we deal with. We have for-profit healthcare organizations. There are proprietorships, professional corporations. They can be owned by one individual. There's unlimited personal liability there. Professional corporations tend to limit those liabilities. There's partnership, limited liability partnerships where one or two more individuals get together. Same disadvantage of proprietorship. And different models roll on. Small for-profit corporations owned by one or more person. There are large publicly held, publicly traded corporations. The Universal Health Services, the CHS, the HCAs of the world, owned by many stock owners. It's kind of got an unlimited life, but they limit their liability of the individuals that are stockholders. Then you have not-for-profit business organizations. They're exempt from property and income taxes, and they don't generate profits for stockholders. Doesn't mean they don't generate profit. You have to generate at least a 5% margin to be able to reinvest in the cost of capital, to buy technology, to hire people, remain competitive on your wages, to replace facilities and infrastructure. We'll talk a little bit about that as we get through the semester. And then you have government healthcare facilities, whether it is the VA or whether county or state entities own hospitals or hospital districts across the country that are governmental in basis. Got some basic types of medical facilities, inpatient facilities, hospitals. Acute care is really what they call, and that's why you saw my title. I'm the president of acute care for St. Vincent's Healthcare in Jacksonville, which basically means I run our 3 hospitals. We have 3 hospitals in the Jacksonville, Northeast Florida community, and so I'm the president of acute care. After World War II, again, same issue. Federal grants aided the proliferation of community hospitals. The Hill-Burton Act, if you've studied that, hospitals grew. Hospitals, excuse me, hospitals have grown over time in decades where funding becomes available. That's why when you go to older hospitals, they look like they've been pieced together, because they have. We had money in the 40s, then we had money in the 50s, then money came available in the 60s again, then there was some money in the 70s, we went through a lean time at the end of the 70s, money came back in the 80s, so they got pieced together. However, today, hospitals and patient beds are declining in most markets. And today you see hospitals closing on a regular basis. When you look at Becker's Healthcare, go on there and search hospital closure and see how many articles in the last year about hospitals closing in communities. One of the real reasons why are the services can't be provided in an outpatient setting. If you broke a leg, you used to go to a hospital and sit in traction for weeks on end. Now it's an ER visit and you're at home. It could even be an urgent care visit and you go home. We do a tremendous amount of surgeries on an outpatient basis that in less than 23 hours, the person goes home. There's no overnight stay. There's a very wide range of services now that are provided, and that also includes home care services where people come to your house and visit you. Those are billed and collected and financed in a completely different model than a hospital, and hopefully we'll spend some time discussing that this semester also. Then you get into the long-term care facilities, the post-acute basis. It's past acute. These are nursing homes, life care facilities. And again, just like hospitals, just like outpatient facilities, they can be for-profit, not-for-profit, government facilities. There's 1.6 million nursing home beds in the United States. Medicaid and Medicare pay for 78% of the payments to long-term care facilities. Why? Who goes into long-term care facilities? Seniors, mostly. And what do they have? Medicare. And then once their income is depleted or they don't have it, then they qualify for Medicaid. So they end up with dual coverage, dual eligible, Medicare, Medicaid, which finances our long-term care facilities in this country. Finances them at a very low rate when you talk about what they are paid every day. Very, very competitive industry, very difficult industry, very cost management side of our healthcare industry. When you get $200 a day to take care of someone, it's a little tough. Hospice care, you see a lot of talk about hospice care. It's kind of getting back to where we were many years ago, decades ago, where we actually are taking care of people in their time of need and when they are passing. And we support that individual during the last part of their lives versus doing everything. When you look at the consumption of healthcare, the majority of healthcare that you're going to use in your life is going to be consumed in the last 2 years you're alive. So it's actually focusing on hospice care and being available to comfortably help that individual navigate the end of life and supporting the needs of their family members. So, told you this was going to be fast, a 26-minute lecture. Here we go. So our summary, healthcare financial management, it's a little unique. We use accrual-based accounting, and we'll talk about the financing of equipment, the financing of capital. We'll talk a little bit about how we get paid, which is wildly different than most other industries. We are full of proprietorships, partnerships with providers, with payers. Physicians are small businessmen and women, but they could also be in an employment model. You could have large chains banded together, or you could have independent freestanding hospitals and outpatient settings and providers. We have for-profit and not-for-profit corporations. We are facing an inpatient service decline, and we are growing in outpatient. Most hospitals in this country, most health entities in this country are 50% outpatient, 50% inpatient. And in certain areas of the country, we're at 70-30 outpatient to inpatient. You're seeing it change. That changes our reimbursement. That changes how we pay for health care, and it changes how we provide health care. All right, a great little intro. Due to the fact you guys have been in classes already in healthcare, none of this was probably new for you, but I wanted to start off very simple this week, ease you into the summer, because starting in week 2, it's going to be put on your seatbelts, hang on, we're taking off. We'll get through this and have a good time. I'm available for questions. As I said on the syllabus and in my notes, email me and schedule a time to talk to me. That's probably the best way to do it. I've provided you with my cell phone number. Text me. If you don't feel like emailing me, text me. Let me know you're one of the students, who you are, and we'll set up a time to talk. It's great if you can give me a heads up in advance what you want to talk about, so I'll have time to research the topic. I look forward to a great semester with you, and look forward to you getting something out of this class. I love finance. I love healthcare finance. It's amazing what it has done for me in my career, having the knowledge base, and it makes me a stronger operator and a stronger president, that I understand the ins and outs of healthcare financial management. It's something I want to impart on you this semester. I look forward to it. Thank you very much.